Has anybody taken the time to explain to you the different levels of hospice? Wait. There are levels to hospice? There's like stages and different areas and different perks? Perks to hospice? Yes, there are perks to hospice. And there's a huge benefit to you, your loved one, with being on hospice that a lot of families don't know about. So in this podcast, myself and Emilynn, our director of nursing, are going to walk through what does it look like for you to fully understand the different levels of hospice. So we're going to walk through those levels together to help you get a good understanding of the true benefit of hospice and how you don't have to do this whole thing, this end of life process alone by yourself. There's hospice around to help support you and your loved one through this process. So let's enjoy this podcast. Let's go. How's it going?
It's good. How are you?
I'm doing good.
Hello, friends.
What's up, y'all? We're back at it. We really want to break down the different types of levels of hospice care. I think families a lot of times they say, "Hey, like, am I gonna get a nurse at the bedside 24/7? What can I expect?" And I think what we want to do with this specific video is just talk about the different types of levels of care. Mm-hmm. So there are 4 levels of care.
There
Is that correct?
4 pillars, yes.
Cool. So we've got routine, we've got continuous care, we've got respite care, and then we've got GIP. So say, for instance, my loved one is discharging from the hospital and they're fairly stable, but the doctor says they're going to need hospice and their cancer diagnosis maybe, and they're like, "Oh my gosh, wait, I have to go home. Like, what am I going to do?" Walk us through the different stages of this specific patient and when they'll need those 4 different levels of care.
Cool.
So heading home, hospice just came to me at the hospital and the nurse said, "Hey, we're going to transport your loved one from the hospital home." What does this look like?
So usually you're started on routine home care.
Okay.
There are a few cases where we will admit straight onto continuous care because we know the patient is imminent. And I can explain that and break that down a little bit. So routine home care is the care that we provide on a day-to-day basis that's not emergent type care. So it may be regular visits from a skilled nurse, the aide, the social worker, the chaplain, the volunteer. All of those disciplines are visiting on a regular basis because they are, to some degree, your loved one is stable. So it's while there's not an emergency. So like our Alzheimer's patients, they're on routine home care because they could be in that same space for 6+ months.
Gotcha.
Their meds are organized. The nurse is just kind of checking in. Yes, they may have little things here and there that might change, like they might get pneumonia, they might get a UTI, they might get a cough or something, but for the most part, there's not an emergency where it requires someone there all the time.
Gotcha.
So that's routine home care.
Okay.
And most of the time our patients start on that care.
Routine.
Continuous care is what a lot of people think of when they think of hospice. They think of a nurse sitting at the bedside 24/7 or somebody from hospice being in your home 24/7. Generally, that care only lasts for 3 to 4 days, sometimes a week, sometimes 2 weeks. Just depends on the decline, the severity, the symptoms, and the nurse is the one who evaluates that plan of that change in level of care. So I tell people whenever they're interviewing hospices, this is a big question to ask because there are a lot of hospices who will say we don't do continuous care for
whatever reason.
Yeah. So it is a very important thing, especially if your loved one is at home, because you don't want to feel like you're alone. Now, that's the caveat of there are Medicare requirements. The nurse has to evaluate and have an actual reason to have a skilled nurse at the bedside.
So what would be like some examples of reasons that the nurse looks at? So let's say, for instance, this patient that the hypothetical is, her name is Betty. Betty's been on routine care consistently, and then all of a sudden there's a couple changes that occur. What are some signs and symptoms of some changes that would warrant continuous care?
So let's say Betty needs medication every 3 to 4 hours for a while. The family could be becoming fatigued, and maintaining that medication administration every 3 to 4 hours, or that changing of a diaper, or that care of a bedbound patient can get fatiguing to anybody. That's why shifts in the hospital are only 12 hours, because after 12 hours you need a rest, you need a break. So that can get fatiguing, and so that for that reason, caregiver strain is one big reason. Or it could be that Miss Betty's symptoms have changed, and she is requiring frequent medication administration that the family doesn't feel capable or is not currently managing those nonverbal cues of what that patient needs well. And so that's why we want somebody skilled at the bedside to say, her breathing's really fast, she's probably in pain. Okay, we tried this an hour ago and she's still breathing really fast and restless. Let's try some anxiety medicine. Okay, her breathing's still really fast. Do we need to go up on that dose of medication? Okay, now she's restless, but she started gurgling. Now what do I do? You know, those skilled attempts at, or if the family has been calling us every hour because they're not sure what to do, you can't live like that for 3 days.
No.
And some people just have a really slow decline. They might be unconscious and moribund for several days, and we say at that point, that's God's timing. Like, it's in God's hands when they're gonna let go. And they could be waiting for a family member or whatever else, and that just gets fatiguing. You have to care for them for a long time, and so sometimes that's the reason. Another reason is facilities don't have the staff to give certain medications at certain hours of the day or hours of the night. And so a lot of times facilities will ask us if we can provide that continuous care because there's nobody on staff to give those medications that that patient will need at 2 a.m. or somebody skilled enough to assess for that need at 2 a.m. And so we have to do continuous care for those patients too sometimes.
So continuous care can happen in any place, right? In any setting for the patient's home. So if they're in a home with family, continuous care can get started. If they're in a facility or even a group home.
Yes.
So continuous care is anywhere where that resident or that patient resides.
Yeah, so our first ditch effort is definitely to try and equip the family, equip the facility, equip the group home, equip the memory care, whoever is taking care of that person on a day-to-day basis, equip them to take care of that person with the tools in your toolbox, with the comfort kit, with whatever. And not every patient needs all of those.
True. And not only that, but I think there's a lot of family members who want to be involved. And so the hospice is there to empower them to actually, go ahead and do this. Call us, we can walk you through it. But a lot of times when they're not comfortable, that's when we can also utilize continuous care. So continuous care, walk us through the business side of continuous care. So there's a round-the-clock nurse that's there, and is the nurse their own staff or another staff, or how many frequently why does another staff come in to check on them? Kind of walk us through that, and what's the protocol to redo or to reassess daily if the person needs continuous care another day.
So there are requirements for continuous care. The onus of the hospice agency has to be the one under the care and direction of the medical director to assess and prove that this patient is appropriate for continuous care. Medicare does reimburse daily at a higher rate while that patient is on that level of care, because a lot of times what happens is, one, the medications cost more, and then two, we usually have to outsource our care. So we're providing that around the clock skilled nursing care of an LDN or an RN. Our agency uses a third-party staffing agency that we trust, who has a group of nurses that can provide that care. And generally, they choose 2 nurses that will choose for the case. The staffing agency decides all of that based on location and all of the things. And then they provide that staff to be at the bedside, and then they switch every 12 hours. So basically we tell our families, okay, you're going to have a nurse come at 8 a.m. and 8 p.m. every day, and then they'll switch shifts basically. But usually it's the same 2 people, so that there's that continuity of care, especially while you're in a home. And then, yes, Medicare requires the nurse from the hospice to make daily visits, because they need to assess that the plan of care is being appropriately followed, the family is happy, the patient is comfortable, and that it's appropriate for continuous care to stay on board, because a lot of times, like, that patient might get comfortable, but then they're needing medication every hour to 2 hours. That's a lot for the family to provide, and that's not something that we could pull out and change. So we want a peaceful death. There are times that continuous care is needed for a caregiver crisis. So we've had patients who their main caregiver is their only loved one that's able to take care of them, and the patient is not safe to be by themselves. The caregiver has some sort of an emergency where they've had to go in the hospital, and we've had to do continuous care for that patient because the patient is stable, but they don't have a caregiver. There's nobody there to take care of them, and they don't have any family.
I remember we had a patient recently that, you know, taking care of their spouse, had to go have surgery, and then the spouse was at home by themselves, so we had to have continuous care until they came back from surgery. So that's really good.
All right, if you're watching this, thank you so much. If you haven't already, please like and subscribe this video. It helps, I think, the algorithm a lot. And I hope this helps and educates you well. So let's keep it moving.
So now Betty is starting continuous care. What are they documenting? Like how is that nurse that's giving all those medications, how are they kept accountable as well from the agency?
So the agency's nurse, the hospice's nurse, is going to go out and assess and look at their documentation every 24 hours, basically. The agency has to supervise that nurse that's at the bedside. So her job is each day, or his job, sorry, to go out and assess how many meds have been given in the last 24 hours, how frequently are you giving it? Do we need refills? Do we need to switch up how frequently we're giving something? Is this anxiolytic not working well? Do we need to switch to a different anxiolytic? Is this pain medication not being effective? Do we need to switch to a different pain medication? And you have the ability to titrate a lot easier when a skilled person is at the bedside because they're familiar with those medications, they're familiar with the safety regimen. So it is our job to ensure that that patient is getting safely cared for. That nurse at the bedside is required to chart every hour. So they have paper charting that they chart. Usually our agency provides a binder to the staff that is going to be at the bedside. And they get like a care plan, their DNR, kind of some family history, and then our agency has to start that continuous care level of care, basically. And so they have to give them a very thorough report of like, hey, here's what's going on, here's why CC is appropriate, and then it is our job to manage that entire care.
That's awesome. That's awesome. That's good to know, because I think a lot of times there are so many steps that have to be reviewed and addressed before continuous care can get started. It's not just that you could just send someone out to be at the bedside. It's a level of care. So like, it's like literally it's a level. Like you've got the first floor, second floor, you know, third floor, fourth floor. So I think that's so good for families to know. Number one, okay, there's going to be someone at the bedside, but also to hold them accountable as, okay, yeah, they should be documenting, right? What are you giving my loved one? Yeah, it's okay to ask questions.
And you should ask questions. You absolutely should ask questions, because not in a threatening way to that nurse at the bedside, but to say, okay, you're giving this. Why are you giving that? Can you explain what is telling you my mom needs that right now?
Right.
Like,
And
she can't talk to me, so how do you know?
yeah, and another thing, I think it's good for families to, when you have a relationship with your nurse case manager that's taking care of your loved one, to call them and reach out to them and say, hey, I just want to make sure I'm understanding what the continuous care nurse is doing. Can you include me? That's really what is so helpful for families when they do that, because it's a team. It's there to help your loved one. So okay, so we got Betty now is on continuous care. Let's just say continuous care isn't warranted for Betty, but the family's just tired.
Oh, yeah.
Like, they're exhausted. You know, Betty is waking up in the middle of the night a lot, but not really in pain, not really in those things. What is one way that someone can get relief, or caregiver can get relief?
This is another pillar of hospice. We can provide something called respite care. So respite is exactly what respite means. It's a break. And so the goal of respite is to provide caregiver relief. Per Medicare guidelines in Texas, we are allowed to offer respite to our patients as often as 5 days within a 30-day period. So basically every month. So we do have patients who regularly utilize the respite benefit, and every single month they go because their family needs a break, or they've got grandkids in another state and they need to go and see them, or whatever else have you. But caregiver fatigue is very real, and so the goal is to provide them relief. The way that works is that the hospice contracts with skilled nursing facilities in various areas in
the Metroplex,
areas in the Metroplex. Thank you. And we contract with them, and every time your loved one goes to that respite facility, we give them a one-time contract for that 5-day stay. And there's ways to work around that, and we can be flexible. You just have to talk to your hospice about like, say you need 7 days or you need 10 days or what that looks like.
And I think the biggest thing is that respite is a level of care that every hospice is supposed to provide, but not every hospice provides it because they just may not have that relationships, or that's another thing to ask the hospice is, do you provide respite care, and how frequently? Some hospices do it quarterly, because the reason why is because you have to manage the resources that Medicare is giving you. So, there's a bucket that they give you, but you have to manage that per how many patients you have. And so, because what happens is, the hospice will then have to pay that facility, the nursing facility, for the days that they're there.
For a set rate.
And so I think it's such a great benefit for families because they get some rest.
So, and then the hospice does supervision visits too. So usually our RN, our aide continues going just as frequently as they have been going. The RN makes at least one visit, if not two, depending on the frequency. And then usually our social worker tries to go and check in, and the chaplain as well too, just to make sure that that patient feels supported and loved, because they are away from their family, they're away from their normal environment. We get that, and so that's it's just our familiar faces in an unfamiliar environment.
Another great thing for families is that sometimes when you're picking a hospice, you can ask them what facilities do you contract with, and then you can actually go visit those facilities too. I think that's a really good, so it puts you at ease as knowing where your loved one is actually going. I think it's a good thing that we've seen over the years, that families really do a good job of. They're like, you mind if I take a look and go visit that facility? We've even
had some families recommend facilities to us because they've had a rehab stay there or whatever else. So don't feel afraid to ask that hospice that you're interviewing what kind of respite facilities they work with, do they offer it, and can we suggest one?
That's awesome.
Because most of the time it is just a contract that can be drawn up. It's very easy.
Awesome. So now we got respite care. Well, now what if Betty is having some uncontrolled symptoms that can't even be managed at home? Like Betty's throwing up everywhere, or bleeding everywhere, or just crazy things. What happens then? I know with hospice, that's not really, you're not supposed to go to the hospital, or what is that? Walk us through that. What is the next level?
So the last level of care that is a challenging one is called GIP, general inpatient. So essentially what that looks like is a hospice has a contract with either a skilled nursing facility that has 24/7 RN on staff, or they have a contract with a hospital or a hospital floor. And basically they can provide hospice care on that unit within a certain, there are constraints obviously. So it's essentially a hospital bed. It's an inpatient unit. So generally those patients are the patients that are requiring, I would say most of the time, intravenous care of something. So let's say Betty has a port and she needs IV Phenergan or IV Zofran to control her vomiting because she is constantly vomiting. Say she has a tumor on her brain and she can't control that, and it is becoming very uncomfortable for her, and nothing oral has helped. You could admit Betty into the general inpatient unit and have IV medication given to her that's more effective than oral medication, which oral medication is a challenge to give to somebody who is frequently throwing up, obviously. So that's one case. Pain is another big one. So sometimes our patients come to us with a very high threshold of pain, and no matter what we give them orally or transdermally or however, doesn't seem to be effective in controlling their high levels of pain. They might have a high tolerance for it. And as they decline, they can't take something orally. That becomes a huge challenge. And so we have to put them on a unit where we can give them intravenous medication because we can't deliver it at home at that rate safely, and monitoring of that is dangerous. And so for that reason, we have to put them on an inpatient unit too. What that looks like, regulatory standby, same way. Medicare reimburses the hospice at a higher rate to pay that unit to do that daily care. Again, it has to have an RN on staff 24/7. So if it's a skilled nursing facility who can handle IVs, there has to be an RN there that can do IV push medications, or basically a hospital. Or it could be a hospital unit. And then the medical director, our medical director, continues to care for that patient. The unit staff will take orders only from the hospice medical director. So they're the ones that are titrating those medications.
So it's basically you're having a hospital, renting a hospital.
It is
to really
basically
take care of that
hospital,
patient temporarily, to stabilize them and to make sure that they are safe. And a lot of times patients will go to general inpatient for a few days, stabilize, and come back home. Or they may actually go to general inpatient straight from the hospital, and that may be their last, time would be at the hospital.
Sometimes you make a good point. A lot of times patients will go to an inpatient unit to get control of something, and then they will come back home. And that is the goal, is for them to pass away wherever they're used to being, and not in an inpatient unit. However, there are some hospices who have an inpatient unit. And so...
And that's another thing, is that a lot of families, they're in the hospital, and then the hospice comes and meets them in the hospital, and then they actually start hospice there. So when they're actually starting hospice there, what's actually happening is that they're actually starting general inpatient.
That's right.
And so they're not actually, the hospital is actually now saying, okay, hey, let's stop covering this. Hospice is now taking over, and then now GIP is started. And
it's kind of on the back end billing, like you don't really even notice it's happening.
And what happens, but in that situation, now hospice has started, but it's actually started in the hospital. And then sometimes, if the disease is taking its toll, then your loved one may not make it, right? And they may pass in the hospital on hospice, and that's considered general inpatient. So that's, I think a lot of times we see families like that. And it's hard to understand that kind of dynamic between the hospital and my loved ones on hospice in the hospital. I think that level of care is so important.
So there are people call us a lot and ask us if we have a hospice house or an inpatient unit. That's a common thing. It's just a matter of doing your research wherever you
different
live.
Regions in the nation.
Most cities have some sort of an inpatient unit. unit. So we have one here in DFW that is a whole building of just hospice rooms, and it's a beautiful facility. And most of the patients that go there have to meet a requirement that they are expected to live less than a week, and it's given their diagnosis or they're transferring from the hospital, and the family is like, no way, we're not letting them die at home. That's too traumatic. And so that's just doing your research of finding the right hospice for you.
No, that's good. That's good. So we kind of broke down really all the levels. You've got routine, respite, continuous care, and GIP. So I know everyone is still talking about former President Jimmy Carter and the fact that he's been around on hospice
Amazing.
For so long.
I'm so happy for him.
I want us to talk about that a little, just really briefly, and then kind of understand the life cycle of a patient and how you can be on hospice for a while and how your days can be your routine. I think a lot of families and just people in general were just like shocked that he went on to hospice. But let's kind of walk through that shock, phase, and why people think hospice means death right away. And in Jimmy Carter's, in his former President Jimmy Carter's, in his life, how being hospice and being on hospice is actually helpful for his family. What are your thoughts on that?
I love it. I'm so happy for him. I think he made the decision to not continue treating, which is powerful, and it's not an easy decision to make. I think he realized that he wanted quality of life over treatment, and so there's that's a valuable thing to say. He came on hospice, and I mean, I can't speak for his plan of care specifically, obviously HIPAA. But he has been on routine home care for most of his stint, and it's probably been, how long has it been now? 3 months?
I want to say maybe April. Since April he was on. He came.
So April, May, June, July, August. So he's probably been on it for more than 6 months at this point. So, like we talked about in our last video, he's probably had his recertification done twice. So a nurse practitioner has come out and said, yes, Jimmy, you are still appropriate for hospice. You're making these tiny little declines. We're going to continue providing this excellent care for you and your family. And that's awesome. So yeah, he's reaping the benefits. And hospice is it's not a death sentence in the sense that you can't leave your home. A lot of people say, oh, I'm not ready for hospice because I still like to go out to lunch with my friends and I still like to go to the movies. Please go.
You can do whatever
Please
you want.
go and out to the movies. I love movies too. That's an awesome thing.
You can be on hospice and go watch a movie.
So yeah, it's the treatment and the medical side of it. So it's having quick access to care. Yes, it might not be that same PCP that you've seen forever, but it's quick access to care of like, oh, okay, we're seeing this decline. I've got this cough. I know I'm more fragile for the next couple days, but my goal is next week I want to go out to lunch with my grandson. That's great. Do that.
Right. I think another thing that, regarding that too, there's goals that are established for hospice patients. There's some hospice patients that are just trying to make it to their grandson's graduation, right? And they're doing some therapy to get them a little bit stronger just while the disease process. And it happens. And I think hospice, Jimmy Carter, former President Jimmy Carter, did a great job of, it's his life, right? And they chose to do that, but it is setting an example because a lot of families don't realize the benefit of hospice. You don't have to do this journey alone, and you're paying into it via Medicare your whole life. So those are dollars that actually belong to you.
I was just explaining to somebody this week that it is the best part of Medicare. Medicare wants you to use this benefit, and they don't want you to use it for 5 days. They want you to use it for 3+ months, because it's the way our medical system is set up to support you in this stage. Yes, not every disease process you can plan for that, and everyone's different, but I think it's a huge benefit. So.
And I think that the beauty behind it is that Medicare issues for each life cycle of a patient roughly about $38,000. It's per cap. It's a hospice term, but that's a lot of money that can be used for your loved one. It's treatment, medications, DME,
Yeah.
staffing.
It can be higher utilized on hospice than it can
Yes.
in and out of the hospital. And
Oh
using
yeah,
ERs.
you'll exhaust that. You'll exhaust that 30,000 in like a week, less than a week,
Less than a week.
in a hospital.
Yeah.
But that's a beautiful thing about hospice, and I think that's why families need to educate themselves, do their research, watch videos like this, like, subscribe, hashtag. But I think those are things that are so important for families. And so, any last closing words in regards to levels of care and Jimmy Carter?
Ask questions. I always tell people, I sent an email to a family member today that, these are the 6 questions you should ask of any hospice you're interviewing. One of them being, do you provide continuous care? Or will you provide continuous care?
Yeah. So that's a good point. Do you and will you?
Yes.
So you're required, these are the levels of care that under Medicare that you're required to, but some agencies aren't able to.
Yes.
Right. So,
and it has to do with that specific agency's business side of it.
Right. Awesome. Well, hope you guys like this.
Jimmy Carter.
Yes. Wait, what? wait, what? Long live.
I pray that he is as happy as he can be.
Yeah. Bye, guys.